Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, my name is Sapna Patel. Welcome to Melanoma Matters.
Hi, I'm James Larkin.
I think I said that inverted, but it doesn't really matter. James, let's talk CheckMate 238 because you had a new publication come out about outcomes after recurrence with systemic therapy. But first, let's do a quick fire. So I'm on this kick of asking you what your number is. What is the number of sunburns that you've had in your life?
Yeah, I don't know. Is the answer to that? I don't. Let me
More
explain.
than a handful?
Possibly. So when I was a kid, I lived in Papua New Guinea for 2 years in the tropics. This is in the mid-70s. And so my parents were careful with my brother and I at the time. But the whole message, I think, about sunburn and skin cancer in the mid-70s, I'm not sure it was really out there. And even now, when it is out there, we know people are getting sunburn. But I think, so, I'm sure I'd be surprised if I wasn't sunburn then, right on the equator.
Do you remember that? Do you have memories of like running around on a beach? And
yes, being on the beach, definitely. But not really being sunburnt. And then I suppose even when I was a kid, I mean, growing up in Cornwall, it's rarely hot, honestly, in Cornwall. You sometimes get a few days each summer where it's really fine, but, there'd be a few times where I may have got sunburn. And honestly, when I used to go fishing with my father when I was a kid, we would be out in the sun all day. And we tended not to use sun cream, and we were covered in sort of protective clothing. But again, I've got kind of Celtic skin. I remember, that kind of warm feeling that you get, but I don't really remember ever having kind of bad sunburn. So maybe I'll answer like that.
Your skin peeled? You remember that?
So I've definitely had that in my life, peeling, but not blisters.
Blistering, no.
So maybe that's a kind of slightly embarrassing answer.
Well, now that the sun is directly across your scrubs and on your face, all I'm thinking about is, where is your mineral? I'm going to get you a powder that you can just powder on so you don't have to put it on like sun cream.
What a great present.
It protects you from aging, right? In addition to the burn.
What's the data there?
Ultraviolet A is the aging rays. Ultraviolet B are the burning rays. We'll give you some zinc oxide to protect you from both, deflect both.
Yeah, obviously I'm careful in the sun now, though, but several reasons for that, I think. But when I grew up,
believe it or not, I've actually had a sunburn, a peeling one. We went to a water park when we were little. One of these like massively unhygienic. There's a fantastic South Park episode about the water park and then peeing in the water park. And then anyway, it's so good. So we went to one of these, it was probably second grade or so, and my parents were treating us and we just ran around all day outdoors in this water park, no sun cream, nothing. And then the next day at school, I remember I couldn't sit back in the chair because my back was hurting so bad that even the clothing on my back hurt, but let alone any, pressure on it. So I kept sitting forward and my back ended up peeling. And yeah, that was my one and only real sunburn. Not blistering, but still pretty bad. And we know what we've now done to our lifetime melanoma risk by having those. So
yeah, with my kids, I was just going to say on that subject that we're very careful. They wear the sort of French vests and hats and everything, like the French Foreign Legionnaires hats and everything, and they're boys, so they tend to be kind of resistant to putting sun cream on, but they've never had sunburn in their lives, so they actually don't know that if it is good, but they don't know that had they got it, it would be painful. It's like, it's no big deal. It's like, well, you've never had it, you don't know what, but it is painful actually for young kids. So,
and you're just resonating heat. You're just like emanating warmth and just like an oven for a couple of days. So yeah. All right. Well, CheckMate 238, citation and top line. You want to take us through this paper?
Yeah, sure. Yeah, so the title maybe is just worth saying: Outcomes with post-recurrent systemic therapy following adjuvant checkpoint inhibitor treatment for resected melanoma in CheckMate 238. Citation, JCO, August 24. Jeff Weber is the lead author, and actually myself and Paolo Asciato are the senior authors. So we talked about CheckMate 238 before, obviously. One of the adjuvant trials that's led to an approval for adjuvant therapy in melanoma. And now the follow-up is actually pretty mature and being reported elsewhere. But really the question for this paper is what happened for people who subsequently relapse, remembering the two arms for the study. There's the nivolumab arm and then there was an ipi arm as well. When those people in the trial got systemic therapy for relapse. So I guess the background to that bit is we've been using adjuvant systemic therapy, I think, widely since probably 2018. So I'm slightly putting to one side interferon, if I'm honest, prior to that. But if we want to call it the modern era or some sort of other description, I don't know how to describe it. And the kind of IPI-10 thing, which we've talked a little bit about before, at least. So the point I'm making here is that we've been using adjuvant anti-PD-1, Nivo or Pembro, as well as dabrafenib and trametinib, actually for quite a long time now, over 5 years. And what information do we have to help us treat the people that relapse? What's the sensitivity to systemic treatment then? And there are a series, multi-institutional sort of retrospective cohorts, but I think one of the nice things about this, bearing in mind my conflict of interest, is it's come out of a trial where the patients were at least, at entry, let's say, relatively homogeneous. At randomization by definition, relatively.
Yeah.
Hear me out. Of course, one of the massive limitations of this, and we say this in the manuscript, is obviously once people have relapsed, they're no longer really homogeneous. And before I stop on this bit, I suppose, and we've talked about this before, but I think it's really important, is that the relapse patterns are really very, very variable. And I think, for example, surgery in particular will have a role in some patients that are relapsing. Radiotherapy might have a role in some as well. And then even with systemic treatment, there's a few different options. Let's say anti-PD-1 based therapy that I think you would to some extent prioritize according to the situation the patient is in front of you in the clinic. So that absolutely par excellence, there isn't a one size fits all for me with systemic treatment, which is obviously one of the issues.
Yeah. Keep going.
I thought you wanted to say something burning there. Anyway, so I won't rehash the patients in the trial because that's sort of pretty well known, but maybe just something about the recurrences, which is in the results. So there were 44% recurrences at the time this was reported in the Nivo arm. 44%, so that's 198 out of 453, and 51% in the IPI arm. That's 232 patients out of 453. So that's another description, I suppose, of the RFS, which we know already. And what we did here was divide the recurrences into early versus late. And the definition of early versus late is basically greater than or less than recurrence than 12 months, basically. So that's the main, kind of division that we made. And so then, to preempt an obvious question, what's special about 12 months? And I think the answer to that is nothing apart from, and I've said this before, I think that's the time it takes the Earth to orbit the sun.
Good one.
Well, true enough, though, biologically, there isn't anything special about 12 months, but go on.
When you guys picked this 12 months early versus late, was that something that was done at the time of thinking about this generation of data, or was it an early decision when the study was created that you said eventually we're going to look at recurrences?
To my knowledge, I don't think this was something very early on we talked about
Okay.
at all. But when it became clear that this was going to be, of potential interest, and I think it is, and of potential clinical relevance, then we had to adopt, some sort of definition. And maybe this is obvious, but obviously, this is categorical, it's discontinuous. But of course, this is a continuous variable. Nevertheless, I think you do. Myself, I think it is right to adopt some sort of cutoff for all the imperfections to try to understand the data. But go on.
So there are two nice series that I think are worth knowing, and maybe we can put them in the fact check. They both come out of Melanoma Institute of Australia leading, but they were global database captures. One of real world outcomes after the use of adjuvant anti-PD-1 therapy, and one discussing real world outcomes after the use of adjuvant targeted therapy. And the adjuvant targeted therapy, I mean, the kind of top line is when you take or give adjuvant targeted therapy, few recurrences in that adjuvant year on therapy. If anything, the recurrences seem to happen after the year is completed. So perhaps after you stop the therapy and take it away, my analogy is that whole year you had your finger, you're like the little boy with the finger in the dam. And then you take it, you finish the therapy, and the cracks start forming and the recurrence happens. As opposed to adjuvant PD-1, a substantial portion of the recurrences, again, with limited follow-up, but it's a real world series, which is nice to see. A substantial, like a third of patients are recurring on adjuvant PD-1. And surprisingly, a lot of those are happening while on therapy. So as opposed to targeted therapy where recurrences seem to happen after you take the drug away, with adjuvant PD-1, they seem to be happening even during the year of administration. So I think that, year cutoff is right. But then, of course, we can be even further nuanced about it. We all have patients where they recur early in their first third or 6 months of adjuvant therapy. And then there are people who recur towards the end of that. Those are potentially different tempos. But collectively, that's one tempo, which is recurring while taking adjuvant PD-1, well, in that year of adjuvant PD-1 versus recurring after a year of initiation.
Yeah, I think those are nice points. I make a couple of comments as well. And I think the business about BRAF targeted therapy not being that common to recur on treatment. So the way I would sort of think about that is what you're doing is you're selecting a group of people who've got BRAF mutant melanoma, some of whom will have microscopic disease at initiation of treatment, right? Whether we can see that or not on scans. And we know that everybody with BRAF mutant melanoma, if you think about the metastatic setting, almost everybody will get some benefit from treatment, right? You look at those waterfall plots, okay? Whereas anti-PD-1 is just not like that. If you think about metastatic disease, you've got some people who are intrinsically resistant. And guess what? If you think about the adjuvant setting, the intrinsically resistant people with got high tempo disease, where we talked about tempo elsewhere, they will progress straight through in the first 3 to 6 months, let's say. So I think that's one thing. And then my other thing, we may have talked about this before or not, is the business about early refractoriness, if you want to call it that, to anti-PD-1. I think you need to be a bit careful in clinic. This comes up quite a lot, actually, where, it is said that the patient's refractory. And my kind of rule of thumb here, in clinic is to, when we discuss these patients in our multidisciplinary meeting tumor board, say, well, actually, has this patient really had an adequate amount of treatment? Are we convinced that this is refractory? Because if we're not, we should carry on treatment a little bit more and see what the next scan shows. So I think there's a catch in there, and we probably got caught out a little bit in the early days. So I'm just thinking to myself that first 3 months can be a little bit tricky with adjuvant anti-PD-1.
Good call. So you don't, So, I mean, I have a lot of thoughts there, but I would, in spirit, agree. Two ways to look at that. One, if they had enough anti-PD-1. The second is, were they just brewing subclinical metastatic disease, and what you're really treating is just metastatic disease that you can now see? anyway, we've talked about this before. Like you said, it's a little bit about tempo. And so maybe I can ask you a question right now. If you have an adjuvant patient who had some bulky nodes and everything got out and for some reason didn't get neoadjuvant therapy because you're practicing in the UK. So they are out, but you're a little bit worried. Maybe it's head and neck and you had a couple of positive lymph nodes. Is this a situation where you would try to start adjuvant therapy quickly? Or is this a situation where you'd say, let me use up the 12-week window where we say it's 84 days to starting adjuvant therapy. Let me just sort of slow use it up to see if you're going to declare yourself in that time period, because then I can use combination on you if you declare yourself with early mets.
Yeah, most patients that would try pretty much as a general rule anyway. And slightly apply that to mucosal as well. We've talked about mucosal adjuvant before. I think if you're going to do it, you wait, till the end of the period, because a load of those patients, unfortunately, are going to develop overt metastatic disease, and I think they would be undertreated with anti-PD-1 monotherapy in that situation. Yeah. So, the people with, can be a difficult conversation with patients, but you have to say, well, look, this is the situation. This isn't something to rush into. We need to really make the right decision here, and I don't think there's any harm actually in waiting. So that's what I'll do.
That makes me feel better. I think I had this conversation with a patient a couple of weeks ago and was a little bit self-doubting myself. Did I just tell them, like, let's wait a month and see? But now I realize it was founded in more logic than just shooting from the hip, as they say. Okay, so then what happened with these early versus late recurrences?
Yeah, so looking now, page 5 in the results. So the people with late recurrences on NIVA had longer PFS than those with early recurrences. So that's the difference between medians is 12.4 versus 4.7. For IPI, the difference is 14.1 versus 7.2.
Interesting. Numerically higher than Nivo.
Yeah, but I think you need to be really careful here, but maybe we'll talk about that in a minute. And then if we just do OS, because I'm just reading out the numbers here. So the median for Nivo, 23.8 months. Why are you laughing?
Because these numbers are a little striking. Keep going.
Yeah. Median OS for early versus late for Nivo was 19.8 versus 42.8 months. And then for IPI, it was 29.7 versus 45. There's landmarks as well, but I'm not going to dwell on that too much because there's already loads of figures.
Both of those are numerically higher in the IPI arm than in the Nivo, and the median is higher in the IPI than in the Nivo. Median OS of 23.8 in the Nivo, that's early and late together, and median OS 37.4 in the IPI. Is this about the subsequent therapy that they get?
Yeah, almost certainly, I would have thought. Subsequent therapies are listed in a table, and that's fairly predictable as well. In other words, the people who've had IPI and not an anti-PD-1 are getting more anti-PD-1, and then the people who've had Nivo are getting more IPI, basically. So all of that is predictable, I would say. So I think these are subgroups of subgroups. There's obviously inherent bias here. The message, I think, or a simple message here, is that if you recur early, and let's say we're talking about nivolumab anti-PD-1 because we're not really using any adjuvant IPI, then that is a bad thing. And I think it's probably, now my own speculation, a bad thing for two different reasons. One is that you are resistant to anti-PD-1. So this is the backbone of our treatment for this disease, basically, in the adjuvant, neoadjuvant, and metastatic settings. The other reason it's bad to recur early is because of tempo. So you've got those two factors, and you've got both together, anti-PD-1 resistance and high tempo, then those patients do not do well. And actually, it's difficult to treat them. And we see this in clinic in the metastatic setting.
Yeah. Was any of this, forgive me for not knowing, was there a forest plot here? Was any of this looked at maybe by like BRAF status?
I think the answer to that is no. We could fact check it, but no, I don't think it is. There's quite a lot of analysis about patterns anatomically of recurrence, for example. I'm not sure too much that was easy really came out of that. But no, not BRAF mutational status, I don't think.
Okay, so it's not that we know. By the way, the recycling truck is here, so you're about to hear all the glass bottles and cans. Maybe
That's
not
brilliant.
from my bin, maybe from someone else's bin, but I did dump quite a number of glass bottles and cans, so it's about to come. So I guess when it comes to, I guess my thought is in these PD-1 early 12-month recurrences, yes, we think high tempo. I wonder if there's any sort of BRAF predilection there, that those are patients with BRAF clones that just didn't get shut down, and then the, immunotherapy wasn't fast enough. Or is it evenly divided, between early and late? Or I'd just be curious to know if your early recurrences, if they tend to be BRAF positive, it almost helps shore up that argument that that's the place to use adjuvant BRAF-MEK, or to use BRAF-MEK is in the adjuvant setting, because lo and behold, when they're given checkpoint inhibitor, perhaps disproportionately they tend to have an early recurrence. All speculation, of course. And then there's this cool table, figure 5, maybe it's a figure, not a table, where you guys describe the recurrence type, local, regional, distance. By the way, I find most places don't categorize that correctly. Local recurrences at the site of the primary tumor are exceedingly rare. What you really have are regional recurrences and then distant. So like, to see this number of local, I just think is a coding issue, but who am I? But more important, I guess, maybe these anatomic sites, anything there's some interesting findings there about brain as a site of recurrence early versus late in the two arms. Do you make anything?
I mean, if no is the short answer. Sorry. But yeah, brain's the 5th column in from the left, right? And you've got the Nevo above in blue. Column? 1, 2, 3, 4, you're right, 4th column. We don't need to edit or fact check that. I think that's just me being bad at counting.
It's all that sun in your face. I get it.
Yeah, look, I'm squinting here. So they're the other way around is the point, right? Okay, Nevo, early versus late, IPI early versus late. Look at those numbers, Sapna, right? I mean, the brain recurrence, 13 patients, okay, for Nevo, 14 for IPI. And so those percentages, you only need 1 or 2 patients to flip one way or the other. So I'd be exceptionally cautious about reading. It's important to have the data, and definitely an important question to ask, because it's the kind of thing we think about, we talk about, we see something in clinic, we think, oh yeah. But I wouldn't really read too much into that at all, honestly.
Agreed. Other than what strikes me is that if I look, so blue is nivolumab. I want to make sure I'm getting that right. Blue is nivolumab. If I look at the brain recurrences, they're almost evenly split in the first 12 months and after the 12 months. So like almost 50-50. Forget what you see there. The raw numbers are 6 and 7. But if you look at IPI, you're getting like 3x, almost 4x the number of recurrences in the first year in the brain versus after. I don't know what to make of that exactly, but it is interesting. I mean, it's
my only take home there is also something we've discussed before is going to be about brain imaging, basically, when you're following up these patients.
That's right.
How important it is, I think, as a sort of take home message. I mean, the other thing maybe we just didn't quite bottom out in that sort of discussion of anti-PD-1 sensitivity and tempo is there is another sort of factor in there, which is that you might have some people, let's say, for the sake of discussion, with a kind of intermediate type of tempo with some partial sensitivity to anti-PD-1.
Yeah.
So, and again, maybe it comes almost back to that little thing we talked about with BRAF targeted therapy, where the patients are on treatment for a year. Okay, you don't see much, but certainly in metastatic disease, and I'm sure we talked about it before, there's a group of patients in my clinic anyway who actually will have nice disease control when they're on anti-PD-1 monotherapy, and then you stop it and it starts growing again, and then you start it again if you can, reimbursement issue there, and then it kind of, it responds again, sometimes over quite repeated cycles of doing that. So I think there's this other, the group of patients who are relapsing later may have had some sensitivity to the adjuvant anti-PD-1. They, by definition, have lower tempo, okay, because they've relapsed later. And so then you go and retreat them again with anti-PD-1, you're going to see some benefit there. So I think that's another thing. I mean, sensitivity to these drugs is not black and white, would be maybe the other point I would make here. There are some grey zones.
Fair. I mean, I think anybody who's recurring after 12 months is going to get a re-challenge with whatever. What do we know about subsequent systemic therapy here? What do we know about combinations? Did people get combinations? It's a little hard for me to tease out of this subsequent therapy table 1.
Yeah, and it hasn't really, as you say, I'm not sure, maybe this is a coding issue or something else, but if you look at it, I mean, I was a bit surprised about the number of people getting chemo, actually, if you look at that. Yeah. So that's like basically, 20% of the people who recur, which I think is high, but anyway, international study and all that sort of stuff. I mean, maybe while we're just on this subject, look at the surgery as well, right? I mean, that is not a small number of patients where surgery is felt to be the right treatment. To my earlier point, you're talking about a third of patients basically there, if you put all those together, having surgery, a little bit of radiotherapy, maybe a bit more. And then, when it comes to systemic therapy, which is the next bit down, it says immunotherapy as a heading, and then it says anti-PD-1, CTLA, which I don't know if that's an investigational agent, and then ipilimumab. And it's not clear, and maybe the data weren't kind of collected or coded in such a way that we could kind of say who's getting ipi-nivo, which is certainly the question I have in my mind, maybe yours as well, because that's my kind of go-to. I have to say, in these types, and we've talked about it elsewhere, in these types of patients, and if you recur, I'm going to want to be treating, in terms of systemic treatment, most people with ipi-nivo if they're not going into a trial.
Yeah, and I just can't tell here if that third of people who are getting IPI and third are getting PD-1 are the same third, but well, and I guess you could say the same thing for dabrafenib. Like they broke out BRAF as a single agent and MEK as a single agent, but presumably if you got dabrafenib, you were taking it with trametinib, though those numbers they're not even.
Yeah. I mean, listen, we would have put them together if we could. So this is post-recurrence therapy in an adjuvant trial, right? So,
and as we started out saying, it's something you guys probably didn't plan at the beginning. And so then, we've said this before, but it's worth saying multiple times. When trials are designed, the quality of that case report form and the quality of that database is going to dictate what kind of data you get at the end. You can't go back 5 years after a trial is closed and add pages to a CRF and get any sort of high, clean data from that. You've got to think of it from the beginning. So from the beginning, we didn't think to say recurrence, date, anatomic location, and then what therapy, spell it out clearly. Then that's how you're going to get CTLA-4 and ipilimumab as separate line items here. not totally understand. Which is
and at the time this trial was designed, and again we talked about this before as well. The big question in everyone's minds is, does anti-PD-1 adjuvant therapy reduce the risk of this disease coming back versus standard of care? And that was obviously the big news. And then as things progress, we of course get interested in what happens when it doesn't work. But but next time there's a trial being designed, I'll look forward to hearing your voice with that important point.
All right. Anything else to say you think about Nivo, IPI, recurrences, and outcomes following subsequent systemic therapy?
No, I don't think so. I mean, I think I think it's nice, and it's gratifying that it got into JCO actually, and I hope the information's useful and in clinical practice. But I suppose the thing we haven't said, but maybe it's trite is that, this is, I think, in many ways, the biggest issue we have in clinic at the moment. The most difficult problem for people who are recurring despite adjuvant anti-PD-1 or neoadjuvant anti-PD-1. So we need to keep working this space.
Yeah, it's a real problem. Well done to you, and of course to Jeff Weber on this lovely paper. Congrats to all the co-authors and investigators, and I think that's a wrap. CheckMate 238 post-recurrence.
Thank you very much.
Thank you.
Yeah, so just a quick fact check on the JCO post-recurrence CheckMate 238 paper. We alluded to the published series of recurrence patterns after targeted therapy with checkpoint inhibitors. So the references 8 and 10 in this paper. So 8 is Barve, that's how you say it, which I don't know, I'm afraid, with which apologies, BJC 2021. And then 10, Karina Owen and colleagues, Annals of Oncology 2020. So I think in many ways that was the sort of background to the paper.
Yeah, not to put you on the spot, but reference 6 here, I just see now, is the 5-year CheckMate 238 biomarker. I vaguely remember this paper, but there wasn't really a biomarker to speak of, right?
No, and again, I don't know if this is a fact check conversation, but a massive amount of effort from BMS and actually the academic, the kind of the grunt work, if I might be so bold, was obviously done by BMS, but they worked really, really, really hard to try and look for something in this space. And I remember all the calls going through the data, and it's complicated. It just is, and nothing really kind of dropped out that we thought was clinically usable. Could we have a testing clinic here in the future that was able to discriminate some of this stuff? I think eventually yes, but I'm pessimistic whether it's going to be anytime soon, unfortunately.
Yeah, as I recall, there was nothing that segregated benefit from adjuvant Nivo over adjuvant IPI. If you were going to be interferon gamma high, you were going to have a benefit from either therapy, but nothing that separated.
Yeah. So, I would just say, congrats to BMS in particular for going looking there. It's not something necessarily every pharma company would do out of adjuvant trials for largely obvious reasons, but they have. And it's a shame that nothing drops out that's easy to use in clinic.
Yeah. All right. Thanks.
Okay.